Welcome to Things You Don't Know. This is the start of a new series of things that we're going to do on minor, quote unquote, minor medical issues. Those things that are like maybe look trivial and maybe sounds trivial, but really bug the crap out of people. And they really want to know why it happens and what to do about it. And I think that is a valuable thing. Don't you, Chandler and Dr. Deneen?
Absolutely, Dr. Weaver.
Oh yeah, we all get these irritations and problems, and they seem minor until it's happening to you, and then you're like, "Oh boy, how do I stop this and quickly?"
And whether
Yes,
we want it to happen or not, sometimes we know it's going to, so we know we just have to deal with it.
indeed. Okay, so this episode is about two different topics that I just thought we should cover. One is hiccups. Yeah, hic. And the other is what, Chandler?
Charley horses.
And yeah, they're very different kinds of things, but hopefully of interest to people. So today's topic, as I said, looks pretty trivial until it isn't, and that's hiccups. Most episodes are pretty harmless and self-limited, but the physiology is very real, and the when should I worry question matters.
And hiccups have a long cultural history, whether home remedies, folklore, and discussions about it, and a surprising amount of medical writing and real and fake cures over the centuries.
And I think that we also need to translate the science into what an average person can do safely, especially when hiccups hit at the worst possible time.
Yeah. Now let's be real clear here. This is educational. It is not diagnostic. And if you are concerned, I certainly recommend that you talk to a medical professional, like a physician, not some soothsayer or bone doctor. I'm talking about a real physician or an ARNP also.
And if you go see this real physician, they're going to tell you do not subject yourself to any risky cures. If a technique can make you choke, can make you faint, or if it can injure you, it's just not worth it, folks.
In order to understand it best, we use a stable structure: what it is, why it happens, home fixes, red flags, and myth busting.
And don't worry, if you get confused, it's all right because we're going to define these terms that sound like medical shorthand. We're going to put them in terms that you can understand.
Yes, indeedy. Okay. So here we go. What are hiccups? Well, they're called, clinically, they're called, in case you want to impress somebody, it's singulatus. Uh, and what it is involuntary, repetitive contractions of the diaphragm and sometimes other respiratory muscles, followed by a sudden closure of the vocal cords that creates the hic sound. It's a kind of reflex arc.
It is kind of a reflex arc, Dr. Weaver. And if you don't mind, I'm going to put this in simpler terms.
I wish you would.
Well, all right. The diaphragm is the main breathing muscle under your lungs. When it suddenly jerks downward, then you pull air in and fast. And then your vocal cords snap shut briefly. That snap is the hic.
Chandler, when you said that, let's just kind of give people a little picture here. The diaphragm is, as you said, under your lungs.
Mm-hmm.
So when it pushes, what does it do? It presses on the lungs and makes you exhale. When it contracts, it makes the lungs expand and sucks air in, right?
Inhales. Right.
Right. Okay. So I'm sorry to interrupt you there, Dr. Deneen. Go
Oh,
ahead.
that's quite all right. What intrigued me in learning about this is that even centuries ago, writers recognized the diaphragm's role, but they didn't know anything about the neural circuitry.
Yeppers. And let's categorize hiccups by duration. And that's how it usually is. Now, acute or transient, that means like minutes to hours that it persists. Persistent is more than 48 hours up to about a month. If you can hiccup for a month, you're in some interesting times, right? And then there's also intractable, and that's longer than a month.
So what you're saying, Dr. Weaver, is these things can vary just depending on the time. So a typical spell after soda or eating too fast is in the acute category. The longer it goes, the more it becomes a symptom to evaluate, not just an annoyance.
Yeah, think of hiccups as a misfire in the circuit involving the diaphragm and key nerves and brainstem coordination centers. Two pathways matter a whole bunch. They're the phrenic and the vagus inputs.
Okay, now let's actually talk about what those mean. When you hear vagal pathway, we're talking about the vagus nerve, a major nerve running from the brainstem down through the neck into the chest and abdomen. It carries signals to and from organs like the throat, the stomach, and the intestines. It is also heavily involved in reflexes like swallowing, coughing, gagging, and this is really relevant here, guys. Reflex patterns that can trigger or modulate hiccups. The phrenic nerve is the main nerve going to the diaphragm.
Yeah, that good old phrenic nerve. Yes. So when people talk about vagal stimulation for hiccups, they mean techniques that change sensory input from the throat or change autonomic tone, potentially interrupting the reflex loop.
Historically, people called it nervous irritation, which was imprecise. Modern physiology keeps the idea, but makes it more specific. Irritation or distension in the upper GI tract can feed into the reflex.
Indeed. So, yes, distension in the upper GI tract. Okay. Common triggers: large meals, carbonated beverages, alcohol, sudden temperature changes, and stress arousal states. Anything that alters breathing patterns or irritates the upper digestive tract can be a cause. Reflux is a classic association.
Now, I want to kind of paint a picture here. I want to add a useful mental model for us. Hiccups aren't one cause, they are a final common pathway. Multiple triggers can push the same reflex button. That's why two people can have totally different triggers but still sound identical.
Yeah. Okay, let's look at some home fixes here. Most safe home approaches try to interrupt the reflex, like breath control, swallowing patterns, and low risk vagal inputs.
Now, here's a practical, low risk sequence that doesn't require gimmicks. Breathing reset, 60 to 90 seconds. Inhale through the nose for 4 seconds. Exhale slowly to 6 to 8 seconds. and then repeat. Brief breath hold after normal inhale for 10 to 20 seconds, and then slow exhale. Slow exhale with no straining. Slow sips of cold water or steady, rhythmic swallowing. Trigger audit. Stop carbonated drinks. Slow down eating. Sit upright. Consider reflux as a contributor.
Yes. So good. The principle is change the inputs into the reflex arc without creating new risks.
Sugar or other sensory tricks show up across different cultures. Some people report a benefit. Mechanisms may involve sensory input in the mouth and the throat, interrupting the pattern.
Now, here is an important boundary here, folks. Techniques that involve chugging water upside down, heavy straining, or anything that risks choking, well, these are not home care. These are hazards. So do not do them.
Yes, I couldn't agree with your emphasis anymore. You can drown yourself, literally, by drinking water upside down.
Yes, you can. You can drown yourself by doing that on literally just 1 cup of water. So don't do it. Do not do it.
Key guidance here: if hiccups last more than 48 hours, contact a clinician. Seek care sooner if they interfere with eating, sleeping, or breathing.
Now, let me make this concrete here. If you can't sleep, you can't keep food down, or you're getting chest discomfort or shortness of breath, please don't wait it out of stubbornness. Do
No,
something about it.
absolutely. You're right on, Chandler. Persistent or intractable hiccups can be associated with reflux or GI irritation, medication effects, metabolic issues, or less commonly, neurologic or cardiopulmonary conditions. Not panic worthy exactly, but evaluation worthy absolutely.
That makes sense. Historically, prolonged hiccups were treated as ominous. Modern medicine reframes that. Prolonged hiccups are a signal to assess, not a reason to catastrophize.
Let's do a little myth busting here, folks.
Sounds like fun to me.
It does to me, too. Myth number one: hiccups mean that someone is talking about you.
Oh, brother.
Jeez.
If that was the case, somebody'd be talking about me all the time. Now, this is cultural, not medical.
Precisely.
Now, the second myth: being scared is the only real cure. No, 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 no. It's unreliable and can be rather unsafe.
It really can. Shocking yourself that way is not a good idea. Myth number three: risky tricks are justified because hiccups are harmless. Oh boy, what a pack of lies. Most hiccups are harmless. The tricks are not, are not. So choose low risk methods first, please. Okay, I'm going to move on to the next thing: muscle cramps, in specific Charley horses, where we separate benign cramps from patterns that deserve a closer look.
Now, I want to talk about electrolytes very carefully here because the internet just treats them like magic. But the reality of this is a little bit more specific than that.
Yeah. Why don't you give us a little scenario here, Chandler?
All right, let's talk about some electrolytes. So, It's 2 a.m. and my calf turns into a rock. My foot points like a ballerina, and I'm bargaining with the universe. Oh, now that right there, folks, that's an old Charlie horse. Ouch.
Yeah, a very accurate phenomenological description of an acute muscle cramp.
And Charley horse is an idiomatic phrase that everyone knows, but few people can define.
Well, let's do that. Let's do that. If symptoms are severe, recurrent, or paired with red flags, once again, seek care, real care. If it's there, this is for educational purposes. It is not to be used as a diagnostic tool. We and Chandler, you wanted to say something about our structure here.
We're going to keep the same structure, like, for example, what it is, why it happens, and then we'll talk about home fixes, red flags, and myth busting. Now, I'll also define electrolytes and electrolyte imbalance because honestly, those terms kind of get thrown around rather loosely. Wouldn't you say, Dr. Weaver?
Oh, you betcha. A Charlie horse. Let's talk about that. A Charlie horse is a common term for a muscle cramp or spasm, often in the calf or the foot. Sudden, involuntary, painful contraction where the muscle temporarily can't relax and it's just sort of fighting itself and it just hurts like 40, man.
Yes, it does. And so to make this more clearer, your muscle just locks up. It's not subtle. It hurts because the contraction is intense. The tissue gets mechanically stressed and pain fibers activate.
I can vouch for that, folks. Older explanations blame the cold, bad circulation, or as with so many other ailments, character flaws.
Jeez. Yeah. That's amazing, isn't it, Dr. Deneen?
There's a moral explanation for everything. It's like in the Bible, if you're ill, that you must have sinned or something. But the shared observation was correct that the experience is sudden, painful, and disabling, but the reasons were muddy.
Yeah. The modern clinical point is that most isolated cramps are benign, but the pattern and context matter. So let's take a look at why it happens. And we're gonna get Chandler to explain part of that to us too. Common associations include muscle fatigue or overuse, dehydration, and sometimes fluid or electrolyte issues. Certain medications can contribute in some people.
Now, let me define, if you don't mind, Dr. Weaver, some of these buzzwords.
Do so.
All right, so first, let's start with electrolytes. What exactly are they? Electrolytes are charged minerals, ions that are dissolved in your body fluids. The big ones are sodium, potassium, chloride, calcium, magnesium, phosphate, and bicarbonate. They matter because muscles and nerve cells rely on tiny electrical gradients in order to fire properly. So, no electrolytes, then no normal signaling. Now, what is an electrolyte imbalance? An electrolyte imbalance means that those levels are either too low or too high relative to what your body needs. Depending on which electrolyte is off, symptoms can include cramps, weakness, tingling, abnormal heart rhythms, confusion, or fatigue.
Yeah, that's the key. Cramps can occur with electrolyte disturbances, but cramps are not automatically proof of an electrolyte problem.
Exactly, Dr. Weaver. So the internet often jumps to magnesium as a universal explanation, but that's not always the case. In reality, cramps are often driven by neuromuscular excitability, plus a trigger, fatigue, and posture and hydration status, or medication effects.
The historical pattern is similar. One simple explanation becomes fashionable, then gets applied to everyone in every circumstance. Medicine works best, folks, when it matches explanation to the person and the context.
And you go back to your little example that you gave us there, Chandler, about the cramp in the early morning.
Yeah, I was getting ready to actually talk about that, Dr. Weaver.
Good for you.
So here is the 2 a.m. protocol, step by step. Stop and gently stretch the cramped muscle against the direction that it's pulling. Calf cramp, you pull toes toward the shin, or you could do a leg massage once the peak pain drops. You can also stand and walk gently if you can. Gradual movement helps to reset the contraction pattern.
Yeah.
This one I think is very important. Hydrate, especially if you've been sweating, exercising, or under drinking that day. After care, heat can relax, cold can help soreness. So you should choose what feels safer for you and better.
Prevention is often simple: gradual conditioning, regular stretching for frequent nocturnal cramps, and stable hydration habits. If cramps begin after a medication change, that is worth discussing clinically.
As with so many things, the boring truth tends to win.
And one practical prevention angle, if you cramp after intense exercise, it may reflect fatigue and neuromuscular load, not moral failure, and not necessarily a neurodeficiency.
Yeah. Now, most isolated cramps are quite benign. Some red flags, though, to be worthy of and take note of. And they would include severe cramps all over your body, or cramps with swelling, numbness, skin color changes, or persistent pain. Another one is cramps plus weakness, or a new and recurrent pattern.
And I would like to add pattern change as a red flag category too. If you go from rare to nightly, or you start cramping in multiple muscle groups without an obvious trigger, then that's a reasonable time for you to get checked out, especially if you're on diuretics, have kidney issues, or have significant dehydration risks.
And there's a couple of issues. You mentioned medications, Chandler.
Yes, I did.
Yeah, statins, and as we said, diuretics, in other words, water pills, some people call them, and some others, even blood thinners can have an effect on that. And if you have a medication change and you start having more cramps, consult with your clinician. Be a good idea.
Historically, people normalized recurring suffering. Modern medical guidance is more nuanced. Normalize what's common, but respond to escalation in pain levels and new patterns.
Yeah,
And here again, I would like to do a little bit of myth busting.
I think that's fun. Go ahead.
All right, so let's start first things first with myth number one. Cramps always mean a magnesium deficiency. Mm-mm. Sometimes it's fatigue or hydration or posture.
Myth number 2, only unfit people cramp. Okay. BS. Fit people cramp too, especially with new loads or endurance efforts.
Yes, they do. Now, myth number 3. If it worked for someone online, it's safe for everyone. Oh, and let me tell you something. That couldn't be further from the truth and can lead to all sorts of unfortunate things, especially when you're talking about supplements or risky remedies.
You know, it's amazing. If you look on the internet, you can find somebody who's offering supplements and remedies. Oh, yes, we researched this and all this other crap. Yeah, right. And it only cost you $100 or $50 or whatever.
Or
And
much less that, sometimes they even just say it's free, Dr. Weaver.
yeah, but I'm talking about the supplements that they like to sell you.
Oh, yeah.
Yeah. That's just a romper room. No, no.
Yeah, stay away from that.
There's a good rule across both medicine and history. Treat folk remedies as a hypothesis, not an absolute proof.
Well, listen, thank you for listening to Things You Don't Know, and we hope you've enjoyed and learned a little bit about some of these weird bodily functions that we have. And hopefully you will call to action. This will be a call to action for you too. If you see something out of the ordinary, get checked out.
I couldn't agree more, folks. There's going to be some more episodes on these type of annoying but sometimes important ailments. We're going to look at a lot of different things. So come back soon.
Yeah, keep your eye out. We got some good stuff coming your way, some interesting things, and come on back and see us. Bye for now.